Hey guys, welcome back to Jab Studies Made Fun for Medicine Part 10. Guys, in this video today we're going to talk about more details in ECG. It's going to be a very simplified version of it because at times people do feel ECG a bit adoring of a task, and let's try to make it easy and so that you can not forget, and at least 1 to 2 questions come in almost all the exams, and the combination of these notes will cover around at least 50 to 60 of those questions. So without further ado, let's start. So guys, before we start our topics, first we need to know little about the electrical conduction system of the heart. So the first and the main firing center is going to be your sinoatrial node, SA node. From the SA node, with the help of its fibers from the right side and the left side, it goes to the AV node. Okay, so from the AV node, guys, which is also known as a a gatekeeper. Why is it a gatekeeper, guys? So that there can be proper contraction of both the sides, the right and the left atrium, and then furthermore contraction of the ventricles. This is responsible. The responsibility is given to the AV node. So after the AVN, it goes to the BOH, which is the bundle of His, right in the left bundle of His, and for the end, finally, it goes to the Purkinje fibers. So let's start it once again. Say it with me. SA node. From SA node, it goes to the AV node. AV node to bundle of His. Very good. And from the bundle of His, it goes to the Purkinje fibers. Very good. Till now, it is clear. Next, guys, we need to know the firing rate of these impulses. What will be there? Since guys, you guys already know that our sinoatrial node is the main. It is also known as the pacemaker of the heart. Why? Because it fires at the rate of around 100 beats per minute. Okay, at around 100. AV node, guys, it's around 60. Okay, bundle of His around 40 to 45. And your Purkinje fibers is quite slow. It is around 16, keeping an average of 16. Okay, so remember, guys, SA node 100. Your AV node around 60, bundle of His 40 to 45, and Purkinje fibers around 16. Okay. Now what you guys have to remember is the maximum conduction speed, which we already discussed last time, is for Purkinje fibers at the max conduction, maximum, which will be there at the rate of, you comment below what will be there, because it was already discussed in the last video. Let us see how many of you guys recall, because this has been asked as a PYQ in physiology in our medicine chapter. Okay. So this is the basic which you need to know, for which we will now continue our chapter. Okay. Next, guys, it's already written over here. So then anyway, moving on. Let's talk about Wolff-Parkinson-White syndrome, guys. What is this syndrome all about? So which we just now talked about our basic details, right? So SA node, AV node, and the impulse goes to the bundle of His and then the Purkinje fibers. Now, guys, in your Wolff-Parkinson-White, there is an abnormality, which is this accessory path. This accessory path, guys, is known as bundle of Kent. Very good. It is known as bundle of Kent. What happens, guys, is that this accessory path, it bypasses the AV node. As I guys already told you that the AV node is the gatekeeper, right? Why gatekeeper? So it controls a proper contraction between both the right and the left atrium. So what happens is, guys, it bypasses the AV node, it bypasses the bundle of His, and it directly goes and supplies the intermyocytes of the ventricle. So it's bypassing this whole path. So whatever it was getting slowed down, it won't slow down anymore, especially with respect to the AV node. The AV nodal delay, guys, that's why it is the slowest in conduction, is around 0.1 second. So guys, if you notice one thing, because it is passing this delay, what will happen to the heart rate? The heart rate is going to increase in a very fast rate. And in the last video, guys, we discussed, guys, that in the heart rate is inversely proportional to the PR interval. The heart rate is inversely proportional to the PR interval. So if your heart rate in this condition is going to increase, what will happen to the PR interval? The PR interval is going to get short. Very good. So guys, in Wolff-Parkinson-White, what is the main defect? There is an accessory pathway, which is known as bundle of Kent. What this does is, it bypasses the AV node. It directly goes and supplies the muscles of the ventricle. What are the histories you're going to get? History will be palpitation, syncope. So this is quite similar, right? But the main feature which you have to remember, Wolff-Parkinson-White, guys, it is an autosomal dominant condition, which means it has to happen in a series with family. Okay, so maybe they'll have a history of in the family of sudden cardiac death. So that will be a proper history will be there, and that you have to be careful and make sure that you see it in the question. Okay, so clinical features like palpitations, dizziness, recurrent syncopal attacks. This though you also had seen in PSVT, but the main thing is family history. Sudden cardiac death, maybe an elder brother who passed away all of a sudden because they were saying because of sudden cardiac death, that will be a prominent history you need to find. Along with this, there are features in the ECG which you have to make out. First thing which we've already discussed, guys, is the PR interval. The PR interval is going to get short. Why? Because the heart rate is getting raised and the heart rate is inversely proportional to the PR interval. One thing is done. Next, guys, we are going to talk about another point which we already talked last time, that is J point. What is J point? It is an isoelectric point where depolarization ends and repolarization starts. So we are going to talk about a new interval over here that is known as the PJ interval. What is happening to the PJ interval in your Wolff-Parkinson's White? First, you will see what are the components of the PJ interval. It is PR interval and QRS complex. Correct? You can see over here, it is PR interval plus QRS complex. Guys, what is happening over here is that you know that the PR interval is shortening because it is bypassing the AV node. One thing you will notice is that over here it is not even getting supply. It's not supplying the septal area also. So the Q over here is going to be absent because Q is septal activation. While the RS over here is going to get slow. Why it is going to get slow is, guys, because this whole pathway, the bundle of His, and then from there it goes right in the left bundle and then to the Purkinje is much more faster than this accessory pathway. What I'm trying to say is, because of this accessory pathway, we are able to bypass this delay. So that is why PR interval is going to get decreased because of heart rate is going to be more. But since directly it is supplying over here, the speed of this is much more slower than the speed of the normal pathway. Okay, so PR interval is going to get reduced, but which was responsible over here, QRS, right? That is going to get slowed. So what happens is that when you are having two things, one, PR interval is getting reduced and the RS, because Q is going to be absent because Q is septal activation and septal activation is not occurring over here. The RS complex is now going to get slower, which is basically means wide. Then the short complex over here and the wide complex over here, both are going to get cancelled. So if one is going to get long, other one is going to get short in one way. I'm trying to explain in one way. If someone had two apples, I gave you one and I have one, it's at the end equal. Alright, so in that way, PJ interval is going to be normal or unchanged because one thing reduced, on the other hand, the other thing increased. That is what I'm trying to say. Okay, quickly, one more time, heart rate which was there was going to increase. So that is why the PR interval is reducing because it is not going to the main QRX supply. Septal branch also it's not going and right in left bundle also it's not going, which is usually actually faster than the intermyocytes, due to which the RS complex is going to be broad. So one is getting less, one is going to be more, both cuts its action and thereby the PJ interval is going to be normal. So if the PJ interval is normal, this is a very important condition to distinguish with another condition. We'll talk about it later. So two features which I just now told you is, one is the PR interval is going to get short. The RS complex is going to get broad, not the QRS. Why not QRS, guys? Because Q is absent over here. Because Q is required for septal activation. And the septa, if you can see over here, the accessory pathway is not passing only through the septa. So there will be no Q wave in this condition. On the other thing, a new thing which is formed in Wolff-Parkinson White, guys, that is known as the delta wave. That is known as the delta wave. Now, how do you distinguish a delta wave from a Q wave? Guys, you guys already know is that the Q wave is a negative wave. It goes down. We discussed there are two negative waves. One is Q and other one is S. There is no Q wave over here. Hence, you see in Wolff-Parkinson's White, there is no negative wave. On the other hand, it is directly going upwards. Because it is directly going upwards, this wave is now called as a delta wave. So what is there in Wolff-Parkinson White? One, you're going to have a short PR interval. One, you're going to have PJ interval is going to be same. Delta wave will be there. Q wave is absent and a broad RS complex. These are all the features which you need to remember. If you don't want to remember the pathophysiology, remember these features. I'll write it one more time over here. PR interval is going to get short. Q is absent. RS is going to be broad. Okay. Thereby, PJ interval is going to be normal. And you will also have a new wave which is a delta wave. So in short, these are all the information you need to know in the ECG findings of a Wolff-Parkinson White condition. So what will be the treatment, guys? So as I was telling you is the intermyocyte conductions are slower than the Purkinje fiber. That is why you're going to have broad RS complex. PJ interval due to which is going to be same or unchanged. Treatment which will be there, it is the main definitive treatment of choice if they'll ask you, that is going to be RFA, that is radio frequency ablation. Now there are two managements. What are the conditions for prophylaxis? Maybe you already got to know that this is going on in the history, so you have to do a prophylaxis. So for prophylaxis, you're going to give flecainide, an antiarrhythmic drug. For acute episodes, which is like acute right now treatment, for that you'll give IV procainamide. So how do you remember? There's kind of same words. How do I remember? Is P, not P. P, not P. Okay, so P is for prevention. Prevention is going to be flecainide and not procainamide. And acute management, it is going to be IV procainamide. So that is how you have to remember. This is the condition of Wolff-Parkinson's-White. Okay, so over here, if I'll see you the main, I just want to show you the delta wave over here. First you see the normal. Normal may you can see this is a P wave. Over here, then you have a Q going down, R going up, and S going down again. So that is going to be your normal, followed by a T wave. Correct? Over here, if you see in this condition, in case of Wolff-Parkinson-White, after the P, you have nothing going down. Directly, it is going up. So this guys over here is the delta wave. Okay, this is over here the delta wave. This is all what you need to know about the Wolff-Parkinson-White. Nothing more than this is required. Next condition, guys, is going to be a similar condition, Lewin-Ganong-Levine syndrome. In Lewin-Ganong-Levine syndrome, you also have an accessory pathway. But this time, guys, notice one thing. The accessory pathway is not directly going into the intermyocytes. Over here, what it is doing, it is bypassing the AV node, which is again, nodal delay is getting bypassed, due to which your PR interval is going to be reduced. Why? Because heart rate, which is increasing, is inversely proportional to the PR. So thereby PR interval is going to be small. But you notice one thing, it is coming back and supplying to, again going to supply the bundle of His. So if the bundle of His is getting supplied, your septa will also get activated. So if septa is getting activated, you will also have a Q wave, you will also have an RS. In Wolff-Parkinson's-White, the septa was not getting activated, that's why there was absent Q wave and you had a delta wave. Over here, guys, you will have a Q wave. So let's talk again. The features are going to be similar: palpitations, dizziness, recurrent syncopal attacks, and history of sudden cardiac death. In ECG features, short PR interval. Why? Because the heart rate is inversely proportional to the PR interval. The QRS is going to be normal. Why? Because after bypassing the AV node, it is getting back to the bundle of His. Okay, and then the PJ interval is going to be reduced. Now, why reduce? PJ interval is equal to PR interval plus your QRX. QRS is going to be normal, but PJ interval is going to be less. So that is why obviously the PJ interval is also going to be less. I hope you understood the difference. In Wolff-Parkinson's-White, the PJ was equal to normal because one was reducing, one was increasing. The management again is going to be same. The treatment of choice is going to be RFA, radiofrequency ablation. For the main acute management, you are going to give IV procainamide, and for prophylaxis, you are going to give flecainide. Talking about the differentiation one more time, every time you need to have a table like this so that you will never forget it. Remember, guys, the accessory pathway in Wolff-Parkinson's-White is known as Kent, whereas the accessory pathway in Lewin-Ganong-Levine syndrome is known as James. Okay, James ka bundle. Next, guys, symptoms are going to be same. You will have a delta wave in Wolff-Parkinson-White because there is no Q, but you will not have any delta wave in case of your Lewin-Ganong-Levine syndrome. PJ interval is normal because your PR is getting less and you're having a broad RS complex. Whereas the PJ interval over here is going to get reduced. Why? Because your PR is getting reduced and your QRS is going to be normal. Okay, treatment is same for all of this condition: radiofrequency and prophylaxis and acute. I hope you understood these conditions. Next, guys, let's talk about some quick information. Like, I don't want to go too much in depth because these are the questions which they're going to ask, what I'm going to tell you right now. If you have a condition of ventricular tachycardia, ventricular tachycardia, guys, can be defined as, see, ventricular tachycardia means the ventricles are getting, it's contracting very fast. How will you define it? Obviously, there will be tachycardia, heart rate more than 100. Then you will have a ventricular contraction. Pre-ventricular contraction means before the atria contracts, your ventricles are contracting. Now, how can you find that in the ECGs? See, in a normal ECG, you will have a P wave, then only you will have the QRS and the T wave, correct? Over here condition, what is happening is, before the P wave itself, you are having the QRS complex. So if you are having the QRS complex more than 3 times, that is known as pre-ventricular contraction. So more than 3 pre-ventricular contraction along with that heart rate. How will you check the heart rate? You're going to check it between 2 RR intervals, correct? So more than 100 heart rate and more than 3 times your pre-ventricular contraction, that is defined as ventricular tachycardia. Now, ventricular tachycardia, guys, can be defined as 2 types: monomorphic and polymorphic. In monomorphic, what it means is the altitude and the amplitude of both of the ECG over here is going to be same. It is not going to be too high, too low. Everything is going to be the same level. So this is monomorphic. Along with this, guys, you have a dip over here, and this dip, guys, is known as your Josephson's sign. So remember, PVC more than 3, heart rate more than 100, Josephson's sign is known as monomorphic ventricular tachycardia. Monomorphic ventricular tachycardia. And you will notice one thing, in monomorphic ventricular tachycardia, the QRS complex is going to be broad. What was the normal value of QRS complex? It was around 2 to 2.5 small boxes, which was 80 to 100 milliseconds. It is going to be more than 100 milliseconds. So these 4 features, broad QRS complex, Josephson's sign, PVC more than 3, and heart rate more than 100, this is known as ventricular tachycardia, monomorphic type. Okay, over here the Josephson's sign is shown over here. This is the Josephson's sign. Okay, next, guys, if you are having same thing, broad RX, which is broad ventricular tachycardia, PVC more than 3, but over here the amplitude is teda meda, means some are high, some are low, some are high, some are low. Now this is known as polymorphic ventricular tachycardia, which is also known as Torsades de Pontis. The management is very important. They have asked this regularly. The management of Torsades de Pontis is going to be IV magnesium sulfate, IVMgSO4. IVMgSO4 is the management for polymorphic ventricular tachycardia. So remember, guys, in case of ventricular tachycardia, the QRS complex is going to be broad. In PSVT, you had a narrow QRS complex. Remember what are the 3 things? Global ST depression, hidden P wave, and a narrow QRS complex. So that is why, again, integrate and correlate. Narrow RS complex is seen in PSVT, whereas a broad RS complex is seen in ventricular tachycardia. Okay. Next, guys, let us talk about ventricular bigeminy. What was the drug, remember, which was saying the most common cause of ventricular bigeminy? It was related to a sodium potassium pump inhibitor. Very good, very good. That is going to be your digoxin. So what is ventricular bigeminy? Ventricular bigeminy basically means is whenever you are having a normal sinus rhythm. What is a normal sinus rhythm? A normal sinus rhythm is when you are having a P, only after P wave, then you are having a QRS and then a T. So means after the normal order, P wave, then QRS, and then T, that is known as normal sinus rhythm. So whenever you are having a combination of 2 things, first normal sinus rhythm, then a PVC, pre-ventricular contraction. So again and again happening this again and again. So the normal sinus rhythm, then PVC, normal sinus rhythm, then PVC. This condition, guys, is known as ventricular bigeminy, seen in case of digoxin poisoning also. Okay, digibind is the treatment over there. Treatment over here for ventricular bigeminy is going to be lignocaine. If they ask you normally in digoxin poisoning, that is going to be digibind. Here the management of ventricular bigeminy, guys, that is going to be your lignocaine. Okay. Next, we already talked about ventricular tachycardia, combination of a broad RS complex, Josephson's sign, and along with that you will have PVC more than 3. If you have a history of a child who has rheumatic heart disease, congestive heart failure, and you gave a drug, and that drug caused ventricular bigeminy, what is the drug? Already discussed, that is going to be digoxin. So for a final outlook, remember, guys, what is atrial fibrillation? I'll be quickly explaining you guys so that you guys can recall it quick. Atrial fibrillation, cases of maybe dilated cardiomyopathy, alcoholic person will be there. What are the X-ray features you'll see? Hidden absent P wave will be there. First one, not hidden, absent P wave will be there. You will have irregular pulse. By checking also, and in ECG when you will check, you will see that the RR intervals are not matching for all of them. And the drug of choice is going to be RACE, rate control with the help of esmolol, anticoagulants, warfarin or rivaroxaban. CE, that is going to be chemical cardioversion using IV amiodarone, and if that does not work, you're going to E, that is going to be DC shock. Okay, atrial flutter, classic feature is going to be your sawtooth pattern. Very good. The DC shock in atrial fibrillation was around 200 joules. Over here in atrial flutter, the DC shock is going to be around 20 to 25. Very good. PSVT. So then PSVT, remember what are the classic 3 features? Global ST depression, narrow QRS complex, and a hidden P wave. Correct? Management, 3 choices. Massage, not working, you have to give them. For what is it for the prophylaxis? Let's start over Veramapil. And if Veramapil is prophylaxis for acute management for sclerotic massage or ice pack, then you will give for IV adenosine. If adenosine does not work, you have to give DC shock. Okay. In case of ventricular tachycardia, guys, mostly the drug which is usually, so you go with DC shock only, but they'll ask you a drug that is going to be amiodarone. Case of Torsades de Pontis, the treatment of choice is going to be IV magnesium sulfate. What is Torsades de Pontis? Polymorphic ventricular tachycardia. Ventricular bigeminy, if they'll ask you, normal sinus rhythm. Along with normal sinus, you will have your preventricular contraction. Ventricular fibrillation, the whole ECG is like, randomly written like this. It will not be able to beat early. Okay. So remember guys, in conditions like shockable rhythm, which we already discussed, you have two types of shockable rhythm. One is going to be ventricular tachycardia and the other one is going to be ventricular fibrillation. In these two shocks, we are going to give defibrillation. The meaning of defibrillation is that it is randomly giving a shock without seeing the RR interval. On the other hand guys, like in PSVT condition, you are going to give cardioversion. In case of atrial fibrillation, atrial flutter, we are giving cardioversion. Cardioversion means that it is giving a shock at the RR interval. That is why it is also known as synchronized DC shock or also known as cardioversion. Okay. Before I talk about the next topic, that is going to be congenital, so not congenital, it is going to talk about heart blocks. Again, I want you guys to see this one more time. The flow of electrical impulse from SA node to AV node to bundle of His, and bundle of His to Purkinje fibers. The firing rate, very important in this topic. SA node, very good, it is going to be around 100. In case of AV node, it is going to be around 60. Bundle of His around 40 to 45. And your Purkinje, the slowest, it is going to be around 16. What is your normal heart rate? Your normal heart rate, very good, it's going to be around 60 to 100 beats per minute. Okay, let's talk about heart block. So the heart block basically means is if there is some blockage in this pulse which we talked about, SA, AV, bundle of His, Purkinje fiber. First type of heart block is first degree heart block, and first degree heart block is between your SA node and the AV node. Okay, usually guys, these conditions, what you have to remember is just in this slide, nothing more than that. It is usually in this treatment you don't do anything. There is no less symptomatic management is there, and they'll ask you to reduce the like carrying heavy weights and stuff like that. Okay, so what are the causes? The most common cause of case of a first degree heart block is going to be marathon runners. Because of their high vagal tone, their heart rate is usually at the lower side. Number one. Second cause is rheumatic fever. What is the classic feature of rheumatic fever? It is going to be Ashkoff nodules. Third, sarcoidosis, hemochromatosis, and endomyocardial fibroelastosis. 5 conditions. Repeat it after me one more time. In marathon runners, in rheumatic fever, sarcoidosis, hemochromatosis, and endomyocardial fibroelastosis. These 5 conditions you need to remember for first degree heart block. Management is like this symptomatic management you have to do. What will be the definition, guys? You will have a prolonged PR interval. And what is the normal PR interval? Very good. PR interval is around 3 to 5 small boxes. So it is more than 200 milliseconds. Okay, 40 into 5, that is more than 200 milliseconds. Okay. Next condition, guys, you have to remember is second degree heart block. Now, second degree heart block, let's come it in the second side. Second degree heart block is of 2 types. One is going to be Mobitz 1, okay, which is also known as Wickman's phenomena, and then you will have Mobitz 2. What is the difference between both of them? Mobitz 1 is an intranodal block. Intranodal means within the AV node. Earlier in first degree it was between over here, right? First degree it was in this side. Now we are going to do within the AV node. Now we are going to discuss a disease which is within the AV node. So what happens is there is already a nodal delay in AV node. There is going to be further more delay. And tell me who was denoting in the ECG the AV nodal delay? That was your PR interval. So there will be changes in your PR interval. So in both Mobitz 1 and Mobitz 2, there are changes in the PR interval. And what are the changes in the PR interval? Now we are going to discuss that. Okay. So now over here, what you have to see is that in Mobitz 1, if you notice one thing, you are going to have your PR interval over here. This is the PR interval. You are finding that there is an increase in the PR interval. The duration is increasing 160, 200, 250, 240. And all of a sudden over here, then you will have a missed beat. After the missed beat, again you will see the PR interval is going to increase. Whenever you are having a changing PR interval, which is on the increasing trend, that is going to be Mobitz 1 heart block. PR interval prolonged, which means heart rate is reducing, bradycardiac type condition. That's why these are all blocks. Mobitz 1, which is also known as Winbach phenomena. Okay, first thing. Next, guys, let's talk about Mobitz 2. Mobitz 2 is an infranodal delay. Now, infranodal delay, which means it is after the AV node, and after the AV node is your bundle of His. And remember, what is the firing rate of bundle of His? It was around 40 to 45. So it is going to be a slower heart rate, right? But over here, guys, you see that the bundle of His is getting blocked. After the bundle of His is getting blocked, you are having Purkinje fibers. So how is your heart working is wherever the block is, after the block, whatever is going on, right, that is going to be your actual heart rate. So if you see one thing in your heart block, in first degree heart block, the block was from SA node in between over here. So over here, the main heart, now your rate is going to be decided by your AV node. Okay, so that is why around 60 would be your heart rate. In case of second degree, in case of Mobitz 1 heart block, you will see that there is a intranodal AV nodal block. So whatever heart rate is going to get decided, it is going to decide by the bundle of His, and the bundle of His is having around your 40 to 45. Okay, okay. Over here in Mobitz 2, you are having infranodal conduction block. Infranodal means the bundle of His is getting blocked. If your bundle of His is getting blocked, the main conduction fiber is going to be your Purkinje fibers. And you remember what was the beats per minute for Purkinje? At an average, the Purkinje fibers were giving 16 beats. Now the normal human heart beats at the rate of 60 to 100. So just imagine a person normal like you and me are having a range between 60 to 100. This person who is having Mobitz 2 heart block, he is right now having a heart rate between 16 at an average of 15 to 25. So that is very, very dangerous. This person can die anytime. That is why among all the heart block, even the next third degree heart block, the most dangerous one is going to be Mobitz 2. The most dangerous is going to be your Mobitz 2 heart block. I hope that is clear by that, because it is infranodal. Infranodal means there is a block in the bundle of His. The next controlling heart rate is going to be Purkinje fibers, and Purkinje fibers is responsible for producing only around 16 at an average of beats per minute, which is very less for the human heart. Next condition, guys, is going to be a third degree heart block, also known as a complete heart block. In this condition, guys, you are having an intranodal block, but the intranodal block is complete. Complete means completely the AV nodal block is not working at all. In case of Mobitz 1, you had an intranodal, but there was some passage. You are allowing some of the impulse to go through. Over here, it is a complete heart block in third degree. So what does complete heart block means? Complete heart block means your atrium is contracting separately and your ventricles are contracting separately. So there is AV dissociation, and I hope if you remember AV dissociation, we talked about in JVP waves, you're going to have a Canon A wave over here. A Canon A wave is seen in ventricular tachycardia and third degree heart block. Whoever correlated like this, very good, you guys are following the right path. This is the way to study well. Okay, whenever you remember any word which you studied previously, again go back to that, try to remember what it was. So like this, it will be a type of revision. You don't have to actually go and see over there, just use your memory over there. Okay, so as I was talking about third degree heart block, complete heart block of the AV node, due to which your atria is going to contract independently and your ventricles are going to contract independently. So as I use the rule, anything what is below the block, that is going to be your main heart rate. So the bundle of His is going to contract, and the flow rate of bundle of His is around 40 beats per minute. So if I ask you which is more dangerous, third degree heart block or your Mobitz 2? Obviously Mobitz 2 is more dangerous, because Mobitz 2 the heart rate was flowing at around 16, but third degree heart block the heart rate is flowing around 40. So this is somewhat still better than the Mobitz 2, right? So I hope you're getting my point. The bundle of His, the heart rate is going to be around 40. AV dissociation will be the lack of coordination will be that. That is why you're going to have large, write this down, you'll have large, which will be basically Canon A waves, not large, it will be Canon A waves. Okay. Another thing which you have to remember is what are the features in ECG for a complete heart block is, normally guys, the number of P waves is equal to the number of R waves every time, obviously, because in the normal sinus rhythm, after P will come your QRS. Over here guys, in case of complete heart block, because in your atria is going to contract based on the SA node. The SA node ka firing rate is 100. So obviously it is going to be much more faster, because the bundle of His, the firing rate is 40. So it is going to be like this. If this is going to be your atria, or here this is going to be your, so this is faster, this will be slower like this. Okay. So make sure you understand this logic. That is why P waves are going to be much more than that of the R waves, because P waves signify atrial contraction over here, and the R wave is going to signify the ventricular contraction. So obviously there are two different things contracting at the different times. So that is why the management in case of your complete degree heart block is going to be dual chamber pacemaker. I hope you understood all about heart block. To give a proper differentiation between all of them, remember guys, in case of primary heart block, the main thing you have to remember is the 5 causes. It will be marathon runner, hemochromatosis, sarcoidosis will be there, along with that the fibroelastosis will be there. But the main thing is that you will have the PR interval prolonged, due to which the heart rate is going to be inversely proportional, so it's going to be less. Second degree heart block, 2 types: Mobitz 1, Mobitz 2. Mobitz 1 is also known as Winback phenomena. In this, the PR interval is going to keep on increasing, while in Mobitz 2 the PR interval is not going to increase. Okay, M2 is much more dangerous. But if you talk about complete heart block, guys, in this complete AVN is blocked, SA, the atria is contracting on its own, the ventricle is contracting on its own, and then you need a dual chamber pacemaker. Okay. Talking about the next management, guys, with respect to the management with your morbid 1 and 2, you have to put a temporary pacemaker, after which find out the pathology. Okay. Now, if you talk about the next condition, which is 6 sinus syndrome, in 6 sinus syndrome, basically you are not able to generate impulse by the SA node, and the SA node is responsible for the atrial contraction. That is why, guys, in 6 sinus syndrome, you will not have P wave, because P wave signifies atrial contraction. That is why the management is going to be a permanent pacemaker. Okay, complete heart block, guys, what you have to do is the AV nodal complete block is there, so that's why you need to have a dual pacemaker, and the heart rate will be followed by the bundle of his, which is around 40 beats per minute. Morbid 2, which is the most dangerous, the block is going to be bundle of his, so the one which is going to function is going to be the Purkinje fibers, and the Purkinje fiber marks at the rate of average was 16, but you can keep around 15 to 20 beats per minute, which is much more dangerous and very dangerous for the life. That's why immediately you have to put a temporary pacemaker. I hope you understood all about this. If we'll talk about the difference between a pacemaker and an ICT, a pacemaker is basically used, pacemaker means to increase the pace. So any condition of sinus bradycardia like heart blocks, you're going to use a pacemaker. Now first you need to know the battery of the pacemaker is going to be for 5 years long. What is the location? The location is going to be below the skin at the left clavicular side, just above the pectoralis major muscle. Now earlier, the first time when they had a pacemaker, it was in 1950, used a single lid pacemaker, and that lid directly went to the right ventricle. Then after that came the dual. In dual, it went to right ventricle and the right atrium, and in case of triple lid pacemaker, it went for all the three, which was your right ventricle, right atrium, and your left ventricle, not the left atrium. Make sure you know this. So what is the difference between your pacemaker and ICD? What is the full form of ICD? It is an implantable cardioverter defibrillator. So what does an ICD does is it tries to control recurrent tachyarrhythmias. What was pacemaker doing? Pacemaker was increasing the pace, while an ICD is reducing the pace. Okay, so ICD, D for deduction, so reducing the pace. So which are the conditions? All types of cardiomyopathies in which you are having recurrent tachyarrhythmias, you will use it. It's basically like a short type DC shock. All of a sudden it analyzes there is a tachyarrhythmia in the heart, it gives a shock to control it down. Conditions like dilated cardiomyopathy, restricted cardiomyopathy, hypertrophic cardiomyopathy, and ischemic cardiomyopathy, you are going to give an ICD. Remember what is the full form of ICD? It is going to be implantable cardioverter defibrillator. Lastly, let us just see some ECG things, so that if even though you don't like ECG, you don't want to read some 3 hours, 4 hours huge videos, watch these videos, part 10, part 9 and part 10, and you're good to go. Normal sinus rhythm, what you have to see? You have to see the P wave, then your Q wave, R, S and T. P wave is going to be atrial depolarization, QRS is going to be ventricular, T wave is going to be relaxation. How are you going to check the heart rate? Between 2 R intervals. Count the big boxes will be there. All the big boxes, 3 and divide the big boxes, you're going to get the heart rate. If you like your life more complicated, count by the small boxes, 1500 divided by the small boxes. Okay. Next condition, guys, ventricular fibrillation. As I told you, you will not be able to see any type of features. You won't be able to see P wave, Q or RS. You will have just a scribble. Management of ventricular fibrillation is DC shock, defibrillation. Okay. PSVT, proximal supraventricular tachycardia. 3 things you have to remember, guys. You're going to have a global ST depression over here. You're going to have a narrow QRS complex, and you will have a hidden P wave. This is T wave, so you will have a hidden P wave. Hidden P wave, narrow QRS complex, and you will have global ST depression. Management, carotid massage, IV adenosine, if not DC shock. Next, guys, hypothermia. Remember we talked about Osborne J wave. Management was rapid dewarming using peritoneal dialysis using warm saline. Osborne J wave, you will see, just comes after the QRS complex. Okay. Inferior wall MI, they'll ask you in inferior wall MI, you'll have ST elevation. And already we asked this earlier, where do you see ST elevations? In which conditions? In which lids? You'll see it in lid 2, 3 and AVF. Remember this, lid 2, 3 and AVF. Over here you can see in lid 2, 3 and AVF, you'll have an ST elevation here, here and as well as over here also. Classic. Okay. So you can see examples of these images below as well. Next you will see again same examples of inferior wall MI. Anterior wall MI is going to be ST elevations seen in lid V1, V2, V3 and V4. If you have ST elevations in V5, V6, this is also known as extensive anterior wall MI. Okay. These are also examples. Atrial flutter, guys, you remember, is going to be classic sawtooth pattern. Management is going to be race, right? Ventricular tachycardia, broad RS complex will be there. Pre-ventricular contractions, already you can see there is no ventricular there is no atrial there is no P wave basically, so you know that this is monomorphic also. Why? Because the levels are completely same. If it was going to be a different morphology, it will be polymorphic torsades de points, and the management of torsades de points is going to be your very good IV magnesium sulfate. Mobitz 1, classic in Mobitz 1, PR interval is going to be like the heart rate is going to increase, is going to decrease. So you'll have a prolonging of the PR interval. So Mobitz 1, the PR interval is going to be increasing, and after that you'll have a sudden dip, and then it starts increasing again. Mobitz is also known as Venn-Back phenomena. In Mobitz 2, you will see that it is going to be an infranodal. You will not have increase in the PR interval because PR interval is going to be intranodal delay, and that is why you will see a sudden skip beat, but you have to see that the PR interval is going to be same. If you see the PR intervals are increasing, which means it is an issue between in the intranodal side, and that is going to be Mobitz 1. If there is no increasing in PR interval and then you have a skip beat over here, answer is Mobitz 2. Over here you can see monomorphic ventricular tachycardia with a Josephson sign. If you see over here, normal complex sinoatrial node is there, P wave, then the QRS and the T, and after that there is no P. Directly you're having a QRS complex. So you're having a normal like a rhythm. Along with that you're having PVC. So you're seeing this pattern: normal then PVC, normal then PVC. This is very good ventricular bigeminy. Case of management of ventricular bigeminy is going to be lignocaine. Ventricular fibrillation management is going to be TC shock. Why I'm showing you all these slides is because usually they will ask you this only. The one thing, when you start practicing clinically, you will see that the clinically to distinguish which is normal, that is going to be much more hard. These are some classic features they are going to ask you amongst these images only. Make sure you study these images very well, and that is all I believe you need to know about ECG. The last thing is, like as we do it always, identify what is this triad. Patient comes with a history of road traffic accident, bradycardia, widened pulse pressure and irregular breathing. Patient also had raised ICT. Identify this triad. Okay, rest, I hope you understood, and I hope this was an enjoyable session for you guys. If you guys have any other doubts, please don't feel shy. Make sure you clear it out, because if you clear your doubts, there is no doubt which is silly. All right, take care. See you in the next video. Bye bye.